Today we are joined by Dr. Timothy Tran, who is an associate professor of clinical urology at Yale School of Medicine. He's going to be presenting today on metabolic stone disease from guidelines to lifelines. Dr. Tran went to medical school in Albany and then did his residency at Brown with both Dr. Brito and Dr. Rotker. They've rejoined the crowd back up at L&M. He then did his fellowship at Mount Sinai, worked at the VA in Providence before joining us at Yale. Please welcome Dr. Tran.
Thank you guys so much. I'll use this keyboard here to advance the slides. Good morning, everyone. I'm so excited to be here and see you all in person and try to give a little talk here. I filled out the form that I, in fact, have no disclosures. I thought I deleted this next little animation because I thought it was kind of like a silly joke, but I'm open to disclosures. So if anyone has any commercial partnerings they'd like to do, that's my Venmo. All right. Another disclosure. Naturally, I understand. You guys are probably sitting here. You're like, you could have chosen any topic. Like, why didn't you talk about cool things that could happen during PCNLs? And yet, you're here talking about metabolic stone disease. Like, I'll be honest. I similarly used to hate this topic as a resident. I'd look at this textbook chapter, and I remember there was one night I sat down. I was like, I'm going to read it. Spent like 2 hours reading it, and I didn't learn anything. I couldn't understand it. It was just all so dense. And when I was in like resident clinic, I would never want to order a 24-hour urine because, of course, I wouldn't know what to do with it. I just hope that the patient had a low citrate level and I could tell them to add lemon to their water. Understandably, it's a complicated topic, right? Even if you kind of understand the guidelines and think you know what to do, every person's a little bit different. Try telling the 64-year-old lady with just a pretty bad stone history, but also overactive bladder, has to wear a pad for urgency incontinence. You say, hey, listen, I've got the perfect solution for you. I'm going to advise that you drink 3 liters of water a day. She's going to be very upset. She's not going to feel like this is helpful advice. But in fact, the reason I've been doing this today is I've been doing this now for a few years. And, of course, I feel like that there's some lessons I've learned. So my goal today is hopefully not just to review these guidelines, but to break it all down for you guys in an accessible way so that you feel not only an understanding of these different metabolic issues, but you have a feeling that you could tailor specific recommendations for the patients that you see. Of course, you'll see many patients. Stone disease in the United States over the last 30, 40 years or so is on the rise. In the 1980s, it used to be like 1 out of 25 people would have a stone. Now it's more than 1 in 10. And of course, that doesn't account for kidney stone episodes. Recurrence rates are very high. You get to 3, 5, 10 years out from a stone episode, the chances of another stone episode go up to 50%. So we ask, all right, well, who should get a metabolic workup? Realistically, if you look at the guidelines from the AUA, it's kind of like anyone that wants one, right? Interested first-time stone formers, people that have multiple stones, and then the high-risk pilots and truck drivers. But naturally, too, there's a debate these days. Like, do you even really need to do it? Because there's no real randomized study that says, hey, you do a 24-hour urine, you're going to markedly reduce someone's kidney stone risk. There have been some population-based studies, large ones, where they look at, all right, amongst patients that have 24-hour urines, like, did they have a decrease in stone disease? The answer is kind of no. And then, third point here, I think you guys probably remember our visiting professor last year, Dr. Clayman, I think on this stage, he's talking about, hey, we probably don't need to do PCNLs anymore. And of course, that gripped me with anxiety. Like doing perks is like 30% of my self-worth. But to make matters even worse, there was a debate where Tajna just did a great job arguing that we don't even need to do 24-hour urines anymore. Oh my God. So understandably, this led to a bit of hurt and concern on my end. I triggered a music cue, and if you can imagine in your minds that song at the end of Fast and the Furious, where it's Wiz Khalifa and like Charlie Puth. It's been a long day. That's what was going through my mind. The visiting professor session had finished, and I was at a crossroads. Right, this is before the graduation. I was like, my whole identity is in telling patients that, hey, not only can I treat your stone, but I can help you prevent new ones in the future. Do some tests to understand why you form them, and keep them at bay. But maybe now I needed to go a separate way for the rest of my career. Fortunately, after that session, Brito took me to the gym. We did some weightlifting, felt a lot better. And then I also realized that there are patients like this. 33-year-old just had his third ever stone episode, and he said it was horrible. And he tells me, I never want to do this again. I will do whatever it takes to prevent a new stone. And so, well, you could see him in your office and say, all right, listen, if you drink like 3 liters and make 2 liters of urine a day, like that'll help. He's like, yeah, pretty sweet. All right. And then you can also, add lemon to your water while you're drinking water. Like, why not? But then also, I'd like for you to try and limit the amount of animal protein you're taking in, right? Maybe about the size of your palm, and then eat more fruits and vegetables. And when it comes to fruits and vegetables, like try to avoid these like oxalate-rich foods, spinach, peanuts, all these things. Gradually, you start to see like the expression on your patient's face change, right? Very happy to, oh my goodness, this is a lot. I also want you to limit salt intake and make sure you take in the recommended daily allowance of calcium. This is a lot to tell people. And I've certainly had visits like this where you do all that. You're like, all right, I provided, helpful information, but, it's ultimately oftentimes an unsatisfying encounter. How much of it really sank into the patient? How much do you feel like you're really able to make an impact? So perhaps there is another way. And the rationale for doing a metabolic workup, in my mind, it allows you to be a bit more precise. You can identify hopefully 1 or 2 things that would really put the patient at stone risk, and then come up with those specific recommendations that they can really focus on, and develop or devote quite a bit more time in the encounter just talking about those 1 or 2 things. I think you guys know the test that you need is just some blood work, a 24-hour urine test. Tell them, of course, not to cheat while they do it, just do it on a regular day. And then always very helpful is a stone analysis. Of course, as you guys probably know, as I alluded to in my first slide, like we don't really do these tests that often. And I think it's in large part because it's not the easiest thing to interpret. So my goal for today is for you guys to be able to look at a 24-hour urine and not feel panicked, but feel comfortable. I'll focus on the common abnormalities, and I'd like for us to be able to get a sense for the different tiers, the different aggressiveness with which we can pursue treatment for each abnormality. And then, yes, there are some exciting, less common outliers that I've laid out in vignettes. And if we happen to have time to get to those, we can go over some slides with them as well. All right, first question. How do you know how bad a 24-hour urine is? Because as you know, when you get one of these tests, there's like literally 23 results that come through with it. Well, I've come to realize that oftentimes a great way to get a sense of this is looking at the saturation level. For example, if they form a calcium oxalate stones, calcium oxalate saturation, calcium phosphate, or uric acid. There's a study that kind of highlights this quite well. This is from a couple of years ago. And what these authors did is they broke patients down into their supersaturation levels for calcium oxalate and basically said, all right, there's like a low, medium, and high low. And then they looked at, all right, well, if we were to, look at the patients that had, multiple CAT scans over a period of time, like how much did their stones grow? And as you probably expect, it was not so much for the people with low, and then, the people with medium, a little bit more, and kind of quite a bit for the people with the higher supersaturations. So in some ways you can look at this now and be like, all right, less than 5, like tell a patient you're in pretty good shape. If someone comes with the 24-hour urine supersaturations 5 to 10, you say, all right, well, hey, we probably have a little bit of work to do, like not too bad, but could be better. And then if someone is like over 10, you'd be like, man, prepare for pain. Like you're gonna have more stones for sure. And so I think, looking at this is certainly a useful consideration. So you can give a patient an idea of where to stand. And then when you look at this, as well as their prior stone history, it can give you an idea of how hard to push an intervention. If, for example, their supersaturation is very high, like 10, and they've had many, many stones in the past, and I think you could certainly justify prescribing medication like potassium citrate or chlorthalidone for them. So let's talk about our journey here today. We're going to have this index patient. They'll have metabolic abnormalities, and it'll change a little bit from slide to slide just for the purpose of our talk. And then we're going to try to look at those metabolic abnormalities and then try to make personalized suggestions for them. You might say, oh, how do we do that? Well, you can look at the context of the patient. Have they had many, many stone episodes or surgeries in the past? Or is it someone who's like 75 and might be another 75 years before they have another episode? Also get a sense of how motivated they are. If they've only had one stone episode, but they say, this is the worst thing I've ever gone through, I never want to do this again, then, of course, that helps to, frame what recommendation you might give them. And then, like I said before, you look at their metabolic risk, and, that gives you an idea, too, of how hard to push some of the more aggressive interventions. So here's our, index patient. He's a calcium oxalate stone former, say like 50 years old or so. Has had a couple of stone episodes recently and has this kind of metabolic panel. So we start off looking at the 24-hour urine. We can say, all right, here the urine volume is low. You might say, all right, well, urine volume, like that's not that exciting. Like, why are we starting with that? But here's a graph that I think can help illustrate this concept. If we were to compare a chart, the importance of something versus its allure, sexiness, sexiness. You could say, all right, someone like Bill Belichick, responsible for so much joy in my adult life as a Patriots fan, but, agreeably not that good looking. Or, on the other hand, you have me, not that important, and if we're being honest, not that good looking either. And then we all, I think, can agree, right? Taylor Swift is the pinnacle of this graph. Largest area under the curve here, you could say. And then what about urine volume? Urine volume, not very sexy to talk about, but in fact, very, very important. And understandably, you might feel silly. Let's say, you had a patient who just had this like horrible stone episode. They did these metabolic tests and they come to see you or me, right? Like, hey, I'm so glad I got to see you at the Kidney Stone Center for Comprehensive Stone Care. And they want to know, what your expert insights are. And you tell them like, oh, I kind of think you got to drink more fluid. Like that doesn't sound that special, but it is. So, why does urine volume matter? Well, you look at this picture here. When you have low volume of urine, you have very densely concentrated minerals. You have different components of the stone that are very eager to connect. And instead of being separated, they're in very close proximity. Whereas if you have more dilute urine, well, they're carefully spaced out, right? Those minerals are going to have a harder time coming together. I don't know if you guys are familiar or religious in any ways, but you may be familiar with the Gospel of Stone Prevention. It says, he or she who drinketh a lot of fluids can overcome a multitude of dietary indiscretions. What do I mean by that? Well, if you look at this basic panel here, someone with a low urine volume and a high urine calcium is going to have a high calcium oxalate saturation. Whereas, if they drink a lot, their urine volume is like closer to 4 liters, with that same urine calcium level, their supersaturation is going to be a ton lower. And so, you could tell them, hey, listen, if you keep drinking that amount, like you don't really have to make major changes because you're going to be in a pretty good spot from a stone risk perspective. So, what advice can you give a patient? They, of course, want to know how much you drink, and kind of the recommendation is about 100 ounces per day. If you're like me, sometimes you're like, well, how much is that really? And it's like kind of 3 liters, or if you look at a different unit, 3/4 of a gallon, like kind of a lot, or 12 cups. And naturally too, if you tell a patient, hey, I would like you to drink 12 cups of water, they're like, come on, that's a lot. How am I going to be able to drink that much? But rest assured, let me give you a real life example. Not as crazy as it seems. Here is my average day, and my colleagues, Dr. Brito and Rocca, could attest to this. I usually come in, I drink my morning coffee. It's in one of these 20-ounce Yeti cups, so you get 20 ounces there. And then, cancer risk be damned, I usually have up to 4 mini Diet Coke cans, each 7.5 ounces, so that's another 30 ounces. This is all in the morning. And then, I usually refill that water bottle, add another 20 ounces. I have a diet ginger ale with lunch. And then finally, to just get a little pick-me-up for the afternoon, I'll grab a little coffee from the lounge, which is, about 12 ounces. So I'm not even home yet, and that's like nearly 100 ounces. It's like very, very doable. Of course, literally in a urology office, there's bathrooms everywhere, so that's a consideration as well. And another consideration is that you could drink at the same amount, but if, for example, you're in this like very hot environment, working outside or in a factory or in an excavator, or you exercise a lot, you're going to lose a lot of fluids of sweating. So for these people, as best you can, try to say, hey, it's hot outside. Like, make sure you drink extra fluid or whatnot. Patients will commonly say, I can't drink that much fluid. Like, I just don't like drinking water. But that's not true, that the only thing that is helpful to drink is water. For better or for worse, a non-controversial statement is that all fluid matters in this case. Of course, there are bad things to drink, right? Like if you drink really sugary soda or like orange juice, that's not going to be great for you. It can put you at risk of metabolic syndrome. If you are someone that really likes sodas, keep in mind that the clear ones are carbonated with citric acid, whereas the dark ones, the colas, are phosphoric acid. And so the clear ones are better for you because it doesn't deliver as much of an acid load to your kidneys. Now, black tea isn't great, and then understandably, you can't tell them to drink 100 ounces of alcohol. That would be quite bad. All right, so back to this patient here, right? 3 stones in 5 years, low urine volume. What do we tell them? Well, try to drink, about that 100 ounces a day. Now, on the other hand, if they tell you, like our second slide, oh, I have really bad overactive bladder, or I just, no access to a restroom, I can't drink anymore. What can I do? Well, let's say, for example, the situation is a little bit more complicated, where instead of there being some other metabolic abnormalities, everything else is just kind of like normal. Our goal here is to try and reduce that overall supersaturation. So even though like the oxalate and the citrate levels are normal, you can still decrease that oxalate level a little bit, or do other things to increase the citrate level a little bit. So I think the take-home point is if fluid increase is just not possible, you can look to other areas, and there's always areas that you can tweak on a 24-hour urine. This is another sound. This one was very silly. It was literally just on to the next one, on to the next, that song. But anyways, on to the next issue. So you probably saw the citrate level was low here as well. And so, of course, we call this hypocitraturia. If you tell that to a patient, they'll be very confused. You just got to tell them you have low urinary citrate. And so what does citrate do? Well, that's a calcium buffer. Normally, you've got these minerals, like I mentioned before, calcium and oxalate or calcium and phosphate. They really like to get together. Citrate is like the bouncer or the police. Say, listen, no, we don't want you to get together. Specifically, what it does is it's supposed to bind onto the calcium in the urine and keep it in a soluble form, keep it in a form where it can't complex with oxalate or phosphate. Of course, if these levels start to drop down, you'll have a proliferation like jackrabbits of the various stone-forming minerals, and you can form a stone. A mystery to me for some time, and quite an exciting discovery, was, why does citrate get low to begin with? Well, this you may or may not recognize from your first year of med school is the Krebs cycle, the citric acid cycle. And a special thing about this is that acidic conditions can fire up the citric acid cycle, and as a result, it chews up the citrate. And then, of course, the urine levels get low. So what can make for acidic urinary conditions? Well, if you eat a lot of animal protein, the amino acids break down into acidic amino acids. And so that's an acid load to the kidneys. Similarly, we'll get into this a little bit later. If you have metabolic syndrome or insulin resistance, this diminishes the kidney's ability to make ammonia, which would typically soak up some of the extra acid in the urine. So then you end up with higher acid levels. Or, of course, patients with Crohn's or gastric bypass or just chronic diarrhea will lose a lot of bicarb. And when that's the case, then they have acid everywhere, including in the urine. We all think about, how do you increase citrate without medications? And, as I alluded to near the beginning, well, you can tell patients to increase their intake of dietary citric acid. They could eat citrus fruits, grapefruits and oranges, things like that. Of course, if you're going to be telling them to drink more fluids, you can say, hey, squeeze some fresh lemon and lime, about 2 of them per day into what you drink. Or if you're very, very creative, if you make your own ice cubes at home, you can tell them to squeeze it over the ice cubes before they freeze, and they've got it ready to go. But when they talked about the acid levels in the urine, one of the things I was getting at is that, there's an overall balance in the urine. And the more it's balanced towards these things that promote a low acid state in the urine, like fruits and vegetables, as opposed to things like meats and carbs, the more you're going to be able to boost someone's citrate production. And so, of course, overall, if you're going to recommend a dietary shift, what would probably make a bigger difference than just telling them to eat an orange or grapefruit on occasion is to try and introduce perhaps 1 or 2 vegetarian meals into their diet, or vegetarian days where they'll be eating less meat and carbs and more of these fruits and vegetables that will deliver less acid to the kidneys. There's non-prescription ways to get citrate as well. Very commonly, you'll see patients taking a calcium supplement. It's usually calcium carbonate. You can tell them, hey, why don't you just switch to citrical, calcium citrate? Because 1, if your urinary calcium is low, it can be helpful for binding oxalate levels. And 2, it has like 6 milliequivalents of citrate in it. So a non-insignificant amount from the citrical. All right, let's talk about potassium citrate. I think we all know, if you've tried to prescribe it before, it has certain downsides. It's a big pill. It's as big as those like 800 milligram ibuprofen. So it's not that easy to swallow. If you prescribe the liquid form, the polycitra, it can be very bitter for patients. They don't necessarily love it, or some people won't love it because it can make them feel a bit of stomach upset. But oftentimes that can be alleviated by taking it with their meals. For some people, and I'm not entirely sure why, the insurance just doesn't cover it as much. And so it can be fairly expensive for them as well. But with all those downsides, we still oftentimes tend towards it because it has a big upside and that it works. It really increases citrate levels significantly. I think if you talk about all these dietary recommendations for patients with low citrate, you'll oftentimes find that unless they're super dedicated, maybe the citrate will move a little bit if you were to repeat a 24-hour urine. Whereas almost a guarantee, if they're on potassium citrate, you'll see a significant rise. We typically dose it, about 40 milliequivalents a day, which is, a good amount when it comes to milligrams. It's usually about 4 of the potassium citrate tablets. So you say, 2 in the morning, 2 in the evening. The liquid form, it's to get to 40 milliequivalents, it's about 20 milliliters, so not a small amount. I wanted to point out too that, of course, there are supplements out there like Kidney Cop. You may even hear ads for it on the radio if you listen to that driving in. And so, proven, components for stone prevention. And yeah, it's got some magnesium and B6, which we will dive into a little bit, but also like citrate. And you say, all right, well, 350 milligrams of citrate, that's pretty good. But remember, to get to 10 milliequivalents, we're talking about over 1,000 milligrams of citrate. So that 300 is really like 3 milliequivalents, probably not doing as much for a patient, especially if the potassium citrate is covered by insurance. Of course, you could consider sodium bicarbonate in people that don't tolerate the potassium citrate well, or sodium citrate. There's some thought, which we'll get to a little bit, that sodium might actually worsen calcium levels in the urine. So if you can pick, potassium citrate's a good place to start. There are, of course, many drinks now out there to help replete citrate levels as well, recognizing that the potassium citrate can be unpleasant in some ways. So things like Moonstone or Litholite, which you can buy on Amazon or at Target, fairly cost effective as well. And so if you have someone that's, I just can't do the potassium citrate, but I'm very motivated, you could perhaps consider recommending something like this to them. Oh, another thing, I thought this for a very long time, but that lemon juice or any dietary citrate, like citric acid, right, should raise the urine pH also, right? But actually, it's like a little bit more complicated than that. Citric acid, of course, when you take it in meals, it can raise urinary citrate levels, but it doesn't have that same alkalinizing effect on urine pH as potassium citrate or alkali citrate. And so if you're, let's say, got someone with a uric acid stone, you're trying to raise their pH, that dietary citrate, yeah, it can increase citrate levels a little bit, but it's not going to move the urine pH in the same way that potassium citrate would. I think perhaps, though, we think about pregnant women, how they typically tend to form calcium phosphate stones, which develop in higher urine pHs. You'd be like, well, I don't want to prescribe them potassium citrate to raise their urine pH, increase their calcium phosphate risk. Well, perhaps dietary citrate is a good recommendation for them, because then they'll have more citrate, which can hopefully reduce the amount of free calcium that's there to form stones for them. All right, back to this index patient, which we've just been making stuff up for. So we've talked about the urine volume and the citrate level. In this case, they've just had a single episode of one stone that they passed. So you think, oh, should we tell them, hey, listen, I'm going to prescribe these 4 giant pills to take? Yeah, probably not. I think you could just say, in this case, with your history, just some dietary changes should be appropriate. On the other hand, similar profile, but they just had their second PCNL in 8 years, and maybe they bled a lot, spent a couple days in the hospital. They definitely don't want to do that again. And so you say, oh yeah, we should do potassium citrate. We should check another 24-hour urine, make sure it's working well for you. All right. High urinary oxalate, of course, is another common issue. And there are a few different ways that it can happen. As you probably know about oxalate physiology, there's the gut, and then the blood that absorbs things from your intestines. Well, normally what happens in the gut is that calcium is there to some extent to bind the oxalate and keep it from being absorbed into the bloodstream. So then just a modest amount of oxalate enters the blood. But, right, if you eat a lot of extra oxalate and there's not extra calcium, then, oh boy, you get a lot of oxalate in the blood. So naturally, we talk about common sources of oxalate in foods, and these are some of the common ones, with spinach being no doubt the worst offender. If you were to look at the spinach level, let's see if this point with this, who knows. If you were to look at the spinach levels on that 24-hour urine, it's like 600 in comparison to some of the other foods that we think of. Also, don't make the mistake of saying any dark green leafy vegetable is high in oxalate. I used to think that as a resident, but spinach like 600, but then kale also dark green and leafy, much less, 13. So not very high with that. I bring this up as well as this other oxalate list that if you Googled, you find a spreadsheet of, because there are resources out there if patients are interested in finding out what my foods, like what am I eating that's like high in oxalate, and if they're not satisfied with you just going over like a brief list of high oxalate foods. But oftentimes you'll find, fortunately, that when it comes to dietary counseling, I can tell patients, okay, yeah, you shouldn't be eating that spinach, but they're like, well, it's really, heart healthy. Like, what can I eat instead? And, I'm a bit at a loss for what to eat instead, because of course, certain things like nuts are very heart healthy, but, not so good for stones. And so I think if you do a lot of stone stuff, it might be helpful to cultivate a relation with a dietitian. Now at L&M, like we don't have like a kidney stone center, a multidisciplinary center where we have a formal affiliation with a dietitian. But I just found one. I was like, hey, do you like talking to people about kidney stone stuff? And she's like, yeah, absolutely. And so it was like, great, because you know what, they can help patients formulate like a real dietary plan, right? Like, as opposed to you just telling them, oh, don't eat this, and try to eat more of this, like fairly vague. They can tell them like, hey, portions, and on this day, like do this and that or whatnot. And then of course, I think another pretty big benefit is sometimes you get kind of bogged down in a room and they're like, oh, listen, what if I eat this? Or, can I eat this instead? And all that. And it's like, oh my gosh, like I can't answer all of these questions, nor do I really want to. So having a dietitian to kind of offload some of those questions to is quite good. And that allows you then to, kind of focus yourself on, all right, should we be focusing more on like a higher level of therapy, or are more natural / dietary things going to be good enough for a patient? All right, more ways to get oxalate into your body. Of course, we've heard of malabsorptive conditions like Crohn's disease or having a gastric bypass. So what happens here is that the calcium's coming by, but it's stuck in fat. And so it cannot do anything to bind the oxalate. And so then as a result, it just flies through, and then the oxalate all enters into the bloodstream. Another thing, a little bit less known, is that you've got these bugs in your intestines called Oxalobacter formigenes. And what its job is to degrade the oxalate. So it grabs onto oxalate and then it just chews it apart so that there's less oxalate going into your blood, therefore your urine. So why is that relevant? Well, if you're someone that takes antibiotics a lot, right? Someone with cystic fibrosis or other conditions where you've got to take a lot of antibiotics, you kill a lot of these bacteria, and then again, as a result, the oxalate can enter into the blood quite freely. So conditions that cause hyperoxaluria, just to summarize those crazy slides: high dietary oxalate, malabsorption, a lot of antibiotics. And then of course, if you have very, very low dietary calcium, there's less of it available to bind the oxalate. And then similarly, having a lot of vitamin C. This vitamin C can metabolize into oxalate, and if you have a ton of it, over 2,000 milligrams a day, that might be a bit dangerous. The other place that oxalate comes from is the liver, and this is a site that's more relevant for those like primary hyperoxaluria conditions, but also for general people with just high oxalate. So the way it happens is you have this preliminary molecule called glyoxylate. And it can become oxalate if this enzyme LDH gets a hold of it. On the other hand, its fate is not decided when it's glyoxylate because it can also become glycine, not oxalate, basically. And there's another enzyme that promotes that. There's a cofactor for that enzyme, which is vitamin B6. And if, for example, you're to give someone a lot of vitamin B6, the thought is that, hey, maybe you can really drive the glyoxylate more towards the glycine than the oxalate. That's the theory, and that's why you see it in things like kidney cup. There are also these like small interfering RNA medications that are newly coming out. One called lumasiran, which inhibits the production of glyoxylate. And then another one called nidosiran, which is still, I think, in clinical trials. And its job is to impair that LDH to prevent the production of oxalate. This will probably be the only time in your lives you ever hear of these medications. So all good. There have been studies, and I kind of alluded to, like the B6 and things like that. There's a thought that it could be helpful in reducing oxalate levels. But to keep things a little bit more simple, there was a randomized study that looked at, all right, if you were to have people do with high oxalate levels, do magnesium, which is kind of supposed to act like the calcium, bind the oxalate in the gut, and B6, which we just talked about. How does that compare to just telling them to do a low oxalate diet? And the reality is those that did the low oxalate diet did better than those that just did the supplements. Okay, kind of had a little bit too much time with this slide here, but I think some important take-home points on oxalate. So there are, of course, many healthy foods that have a lot of oxalate. So you don't want to tell people to, cut out all their oxalate intake, but you do want to try to identify the ones that are really, really, really high, like spinach, and consider substituting that one out. And then maybe just moderation with other things like nuts and potatoes. Another key tip that you can give people is, hey, we talked about how calcium can bind the oxalate. Well, if you time the calcium intake with some higher oxalate foods, so if like, oh, I like to eat nuts, we're like, oh, maybe have some cheese with your nuts, or have some dairy with your yogurt with your blueberries or whatnot. That can help, in theory, neutralize that absorption. All right. So, looking now at these three metabolic issues for this patient, the low urine volume and high oxalate, and, obviously pretty severe stone disease, you tell them, hey, make sure you drink a lot of fluids, emphasize that. And then probably, say potassium citrate, and then maybe even if we're going all out, refer them to a dietitian. On the other hand, if there's someone that's like, single stone episode, I think if you were to recommend all of that, they would be, a bit perplexed. And so you say, hey, just try and drink more than you're drinking now. And, give them a couple tips for increasing the citrate level with dietary interventions. And then maybe point out, hey, if beware of these few foods that are higher in oxalate. So, simpler recommendations, like a few of them, but probably good enough considering that someone made it to 68 with just a single stone. And then you can keep an eye on things for them. All right, boy, this is getting pretty heavy, right? All these different metabolic issues. Now we have a hypercaseuria to talk about. Oh, thank goodness, a break. Grimace, what are you doing here? Who is this? Well, this is a vignette. So this patient says, my doctor wants me to lose some weight, and well, I don't have high blood pressure or cholesterol because I take these medications for them. And yeah, like I've passed some stones before. Some are dark, and then some are kind of a tan yellow color. So who is this? Well, this is, yes, it's Grimace, but it's also the face of metabolic syndrome. So what does metabolic syndrome have to do with kidney stones? I was asked this once in a residency interview, and I just made something up. It was totally wrong, and obviously didn't match there. But this is the answer. So insulin goes to the kidneys and says, make more ammonia. And you say, ammonia? What is this, a cleaning solution? No, its job is to act as a buffer for free acid in the urine, and it can bind that acid. It becomes ammonium, and then you can maintain a normal-ish urine pH. What happens when you have insulin resistance? Well, it just doesn't work as well. So you don't make as much ammonia, and then as a result, that acid is free, and your urine pH goes lower. So you might wonder, you're like, why is there no quality content in this talk? It's because I spent all this time making animations. Anyway, what does acidic urine have to do with kidney stones? We kind of alluded to it before, but also it allows for uric acid to precipitate. Uric acid has a pKa, as in like a pH level, where if the urine is below it, it's going to start to crystallize, go from a liquid to a solid form. Yeah, you get some more uric acid. But then also that more acidic urine, as we talked about, is going to lead to decreased citrate levels in the urine, which could favor calcium stone formation. And then to make matters worse, the uric acid crystals are like a nidus or like a glue that makes it easier for stone formation. I don't know if you guys have experience with this, but like sometimes when you do PCNLs for patients that have uric acid stones, you get the access, you're like, oh, sweet, like, we're in the collecting system. And then you're trying to pass the wire in, and it feels like really gritty, like it's difficult. You sometimes have to pass the stiff back end of the wire in. Like, why is that? It's because the uric acid is inherently just somewhat of a sticky substance. And, you can imagine that as how it works in terms of aggregating stone particles. Yes, there it is, calcium oxalate joining to it. Oftentimes amongst patients with metabolic syndrome, say, oh, they eat a lot of animal protein. Like, for example, what I love to do in the winter and summer, all months, is grill meats like ribs and try to make brisket or pulled pork. This is, nothing makes me happier. But, well, how good is it for the kidneys and my kidney stone risk? If you eat a lot of animal protein, there are a few things that happen. One, as we mentioned, a lot of amino acids that are acidic. They have that sulfuric acid associated with them. So you have the acidic urine. Also, you have these break down into purines, right? And some more purines means more uric acid in the urine. And then lastly, have you ever eaten like beef without salt or chicken without any seasoning? Of course not. Like you're going to have to season it somehow so it tastes good. And so you take in more salt. And then as we'll get to, that leads to more calcium in the urine as well. So eating a ton of animal proteins certainly poses significant risk for stone formation, both uric acid as well as calcium. What about this? I think we all see patients who have uric acid stones and they say, oh yeah, I saw a urologist like 15 years ago, and they're like, just take allopurinol, you'll be good. But no, that's a misunderstanding of how these stones form. They form because the urine pH gets low. Not really because there's just high uric acid levels. So if you see someone uric acid stone, they have a normal uric acid level, allopurinol or uroloric, any of those medications that are going to reduce the levels aren't going to be very helpful. On the other hand, if you do see high uric acid levels and it's a calcium stone former, you can consider once daily allopurinol for them, because as we talked about, it's that nidus, it's that glue that can help join those molecules together. All right. How do you treat low urine pH? As you can probably imagine, try to take in less animal protein, more fruits and vegetables, that seesaw that we were talking about before, and then potassium citrate. What about this? You've got someone that formed uric acid stone. It's 100% uric acid. They've had a number of interventions, And you look here, and you say, all right, well, their urine looks pretty good, the volume. Their pH is low, and their oxalate's high as well. Like, what do you think about that? Well, as we kind of talked about, it doesn't really play a role in uric acid stone formation. So this is why stone analysis is important, because it helps guide you in terms of what direction to take for the recommendations that you give a patient. You can tell them low oxalate diet, probably not going to make much of a difference in terms of their overall stone risk. So focus on the abnormalities that you know to be related to the stone, in this case, the uric acid level and the very acidic urine. All right, so bye-bye, Grimace. Nice to see you. Back to reality, this high urine calcium level. And this is, I'll say, our home stretch. We got about 15 minutes left, and this will take about 10 for us to cover. So let's say you have a patient with calcium oxalate stones. Very commonly, they'll say, oh, I got my results in my chart and said calcium oxalate. And, I'm very proud to tell you that I've cut out ice cream, cheese, yogurt, and milk. And how do you react? Do you say, oh, my goodness, I'm so proud of you? No, you say, no, that's not what we want to do, because this is a common misperception. Dietary calcium is generally a good thing. There have been studies that show that people that take a low calcium diet, as opposed to people that take a normal calcium diet, those people with low calcium diet are going to have a higher risk of stone formation because there's more of that oxalate being absorbed. So the AUA guidelines are, taking the recommended daily allowance, a normal amount, which is usually about like 4 or 5 servings of dairy a day. And as we said, the oxalate plays a role in terms of limiting, or the calcium plays a role in terms of limiting the oxalate absorption. I think also, if you have a patient that's not that convinced, you can also tell them that it's probably better to pass a kidney stone than to, break your hip. A kidney stone, something that, we could fix, relatively minimally invasive surgery. You break your hip, that could be a major life changer. All right, a couple ways that you can get high calcium levels in the urine. One pretty straightforward way is this high dietary sodium leading to high urinary sodium, which then acts like a magnet. It pulls calcium into the urine. The mechanism, thank goodness there's no nephrologist in this room, is quite a bit more complicated than that, but that's essentially what happens. It's like a magnet. And so if you see someone and they have high urine calcium on their 24-hour urine, one of the first things, or the first thing I then look for, is what's their urine sodium level? Because if that's high, then I think that would be the first place to target. It makes a big difference too. There have been some studies that would suggest that if you were to reduce that sodium level in the diet by about a teaspoon, you can reduce urinary calcium by like 50, which is fairly significant. So as I mentioned, now patients will say, well, I don't really eat much salt. I don't understand where this is all coming from. And then you could ask a few follow-up questions that might yield results. Like, hey, do you go to restaurants at all? Like, oh, I guess I do some Uber Eats and stuff. And like, okay. And what about chips or snacks? And they say, oh, yeah, I guess, that there can be some salt involved in those. And they say, cold cuts, I usually have like a ham sandwich for lunch each day. So there are a lot of insidious sources of salt beyond just the salt shaker. If too, at the end of asking, this is like my only 3 things I could think of, I can't figure out where the sodium is coming from. And I said, might be a good idea for you to meet with a dietitian. They could probably help you with that. All right, let's talk about renal leak. So, the kidney is supposed to reabsorb most of the calcium that it gets. It happens at the proximal tubule. Well, for some people, the proximal tubule doesn't just do its job well enough. And so then as a result, sometimes you'll see some blood changes, not always, but in theory, the PTH level should rise. And then as a result, there's more calcium coming in from the gut. And then also in a bad way, less bone mineral density because more of the calcium is being resorbed from the bone. So how do you treat that? Well, of course, yes, you can try to limit sodium intake, but primarily we reach for thiazides. And, it could be chlorothalidone, hydrochlorothiazide, or indapamide. And what they do is they help the proximal tubule out, increase the renal absorption of calcium, and importantly too, bring that calcium back into the bones. There's been studies that show that. Of course, just like potassium citrate, it's got its own side effects. A lot of times people start it and just be like, I can't continue it. Like, I don't feel good. I feel dizzy. And also, you might want to monitor for changes in their electrolytes, uric acid levels, glucose. It could decrease their potassium or even their urinary citrate levels. But the upside is it works. It's very rare that you start that on someone and it doesn't make a significant difference in their urine calcium level. It especially works well if they're also able to control the sodium that they're taking in their diet. And it's just, in comparison to like 4 pills of potassium citrate, it's just like 1 pill a day. If you have someone who's like, I don't feel great when I take it, but I kind of can if it's really going to make a difference, you can even tell them to just space it out, like take it every other day, take half of the dose. Some is better than none. Now, you guys might say, you talk about thiazides, like, do you even pay attention to the New England Journal of Medicine? I'm like, well, not really, but I do look at tweets and stuff. And there was this recent study that came out just this March. And their conclusion was, all right, well, amongst patients with recurrent kidney stones, it didn't really make much of a difference whether they took hydrochlorothiazide, a thiazide. And it didn't matter what dose they took, the 12.5, 25, or 50. So should we just throw them away then? Well, I'd say this. We were just talking about prescribing thiazide specifically for people with hypercaseuria, right? So we had a target, and this is targeted therapy. The thiazide was trying to hit that target. In this study, the randomized control study, they included anyone with recurrent calcium stones. So if you dig into table 1, you see, gosh, up to 40% of those people included in the study didn't even have hypercalciuria. So this is kind of testing an older adage, which is, for people that form recurrent calcium stones, you can prescribe thiazide. Also, if you were to nitpick and say, all right, what was the dosing schedule like right on? Because they were doing hydrochlorothiazide like once a day, but in our guidelines, it says to try and do it twice a day, unless you're at the 50. Finally, if you looked at some of the before and after for these different mineral levels in the urine, you would see, let's say for urine sodium, we talked about how, for a thiazide to work its best, you want to have urine sodium levels or dietary sodium controlled. None of the groups really had great urine sodium levels. So it was, maybe not the best environment to test the thiazide, or maybe the patients weren't counseled in the best way. Similarly, if you looked at the calcium levels, it did kind of get better in all of the patients. So it seemed to be doing what it's supposed to do. If you looked at oxalate levels for patients, of course, not relevant in terms of calcium metabolism, but in terms of calcium oxalate stone formation, for sure, it got worse in all of the patients. And that is not like a side effect of the thiazide. And then finally, no surprise, we talked about like what gives you a sense of if things are working. It's the supersaturation levels. And they didn't really shift in any of the groups from pre-treatment to post-treatment, except for the ones that had the properly dosed thiazide, the 50 milligrams daily. So my thoughts are, of course, like I could never do a randomized controlled trial. So credit to them for doing that. And I think it helps to show that, yes, this older theory of empiric thiazides for people, like, oh yeah, you keep forming calcium stones, we'll give you a hydrochlorothiazide, probably not a good idea, especially given side effects associated with it. But there are many factors that impact kidney stone saturation. And if it's not calcium that you're trying to treat, then that's not going to be as effective. Most, I think, urologists and nephrologists will go with chlorthalidone because it has a longer half-life than the hydrochlorothiazide. It's like a full day, so it's just once daily. And then, so for me, not really practice changing. Okay, let's talk quickly about parathyroid hormone and what it does. So it goes to the bones and it says, hey, I need more calcium and phosphate, so the bones produce more of that. It goes to the kidneys and it says, hey, make this enzyme, which then activates vitamin D, which then goes to the gut to increase the absorption of calcium and phosphate. So, of course, people with high PTH and calcium levels can have primary hyperparathyroidism, and treatment for that is surgical. Another case, so someone that's formed some stones, they've got a high PTH, but their calcium's normal. You always got to remember, like I remember first a couple of months I was out as an attending at the VA. I was like, oh my God, I found someone with a high PTH level. Their calcium was normal. And I was like, I'm going to refer you to like the endocrine surgeon. You're probably going to need parathyroid surgery. But then what was the first thing they checked was the vitamin D. And then that was low. So yes, too little vitamin D can lead to an elevated PTH. Like why? Well, it's, you don't have as much coming in from the intestines as you showed. So you have then low serum calcium, which leads to a secondary hyperparathyroidism. You might wonder too, like, gosh, does this play a big role in terms of stone formation? You've got a high PTH level. Well, not really. It's you don't have extra calcium in your system. It's actually a lower calcium level in your system. And so you're not sending more calcium to the kidneys with this secondary hyperparathyroidism from vitamin D. So you usually tell people, take about 2,000 international units daily, and you tell them the good news for your patients and also for me is you can take it as a gummy. It's very yummy to take. And you can find this at Costco or many other pharmacies. Can you take too much of it? The jury is kind of out on that because, in some studies where patients took like a lot, 20,000 units a week, you would see on their urine that there's hypercaseuria, but no increase in stone formation was seen. So you say, all right, well, does it mean that, it doesn't lead to stone formation? Well, not necessarily, because it, of course, takes some time for stones to form, and that time could have been longer than they had done the studies. So just try and, if you're going to make recommendations, tell them not to do some incredibly high amounts, but ideally about 2,000 a day. All right. So here we have this high urine calcium level. Someone with modest stone disease say, all right, we got to focus first on trying to reduce your dietary sodium levels, and then maybe we could recheck 24-hour urine for you. Someone on the other hand, fairly severe stone disease and their sodium levels normal, I think it's quite worthwhile to have a conversation with them about starting a thiazide. And then finally, what about in this situation where they have a little bit less significant stone disease? Well, maybe, yes, you think it's renal leak, but a thiazide every day with potential side effects, maybe you or the patient don't feel like it's worthwhile. So they can work on the other thing, the urine volume, and then see if over time any new stones start to form. Finally, all right, yeah, this is the hyperparathyroid person. And then what about like a normal 24-hour urine? Like everything looks great. What do you do in that case? That's at times a conundrum that you'll encounter. I think the first step is to ask a patient, did you make any changes to your diet before you did this? Because a lot of times you'll find that they had, and then you can commend them like, oh, look what you did. It's fixed everything. You should be in pretty good shape. And then on the other hand, if they haven't, you can, as we mentioned before, keep in mind that all of these levels, it's not like a yes, no, pregnant, not pregnant. It's like a spectrum of risk. And so just because their oxalate's normal and, or 38, and that counts as normal because the high is 40, doesn't mean that that's an area that might not need some fine tuning. And you can also, of course, consider repeating a 24-hour urine, because one of the limitations of a 24-hour urine is that it's just a snapshot in time. It's telling you not what their whole life is in terms of stone risk, but just what that one day was. All right. So finally, with all these things being said, I usually close with patients telling them, listen, top 3 recommendations are to drink a lot of fluid, and then all this other stuff we talked about matters after that. But you get the most bang from your buck if you can by drinking a lot. And takeaways, we kind of talked about this already in terms of individualizing. But I think another takeaway for all of you guys, challenge yourself to order them. And then if you, have a question like, oh my gosh, what have I done? I ordered this and I have all these crazy results. Feel free to message me in Epic because nothing makes me feel more important like knowing something that other people don't. So. All right. Thank you all. So yes.
Tim, great talk.
Thanks.
We know that people with neurogenic bladder spinal cord injuries make a lot of stones. What is the use of 24-hour urine in those situations?
So I think what we also see with those patients is they tend to be oftentimes infection-related stones. So didn't talk about that in this case, but if it's an infection-related stone, then the general thoughts for treatment there are one, to try and remove all of those stones. Sometimes these infection stones can be a little bit fluffy, so trying to do your ureteroscopy and laser, it's a little bit less effective. So if you have to do a perk to get it all out, you do that. And then, you could consider for a period of time, like low dose antibiotic or something like Hyprex to try and maximally sterilize your urine. I think another thing too that happens with people with neurogenic bladder, it's oftentimes in combination with like spinal cord injury. So they're not like, up and about, walking, running. And so a lot of times you'll see like, oh man, I did a great job like lasering the stone, just turned it all into dust. But instead of their dust passing, like they get another CAT scan like a year later. It's like, oh my gosh, like the whole stone is reformed. You go back up there and do your ureteroscopy, like, oh, it's just like dust that's there. So I think one of the risk factors for them, of course, infection, and then two, just the fact that they're not as mobile. You can think too that lack of mobility is going to decrease their bone mineral density, and that can change some of the calcium metabolism. So if you pick up something related to that, that's another area to address.
So some of them may benefit, like, you know, because they absorb calcium because they don't move, you know, the thiazide. I mean, so you'd evaluate them with a 24-hour urine?
I think it's worthwhile considering. Yeah, it depends too. Like if, for example, their stone's like 100% struvite, then I think there's less of a role for picking something up there. But if you see one that's more of a classically metabolic stone, I think it's helpful. All right. Thank you guys so much for having me in this sauna today.